paper that we published in CA last year on behalf of my team. So let's get started. So again, my name is Alex Liber, and I'm a senior scientist in ACS's Economic and Health Policy Research team. We're part of the intramural research department, and a significant part of our portfolio is making tobacco control policies better. We particularly focus on the economics of tobacco control, and effective taxation of tobacco products is an enormous part of what we do. Next slide. Today, I'm here to tell you some good news and bad news about smoking in the US. Let's start with the good news. We're doing really well, and we should celebrate, cautiously and briefly. Adult tobacco, cigarette smoking prevalence is down to 14% for the first time in many decades. Youth smoking prevalence is down to around 8%, with the caveat that youth use of other tobacco products is up significantly, but that's a topic for another day. These lower smoking rates translate into 8 million fewer tobacco attributable deaths in the last 50 years or so. The enormous gains we've seen in life expectancy in the same period are about a third of these are attributable to this single decline in smoking rates. The American Cancer Society has had a significant part of the success, and we should all say yay to ourselves and all of our partners who helped make this happen. It's been a huge partnership across many wonderful organizations and individuals and government officials and agencies. But let's get to the bad news. It's already up. Smoking has declined in almost all discrete groups in the United States, but the decline has been slower in some groups, and it's those groups that I'm going to highlight today. We've had to keep in mind that there are still more than 35 million adult smokers in this country, depending on how you count them, and 1/2 to 2/3 of them will die prematurely from a tobacco attributable disease if they do not quit. Moreover, we should all remember that these deaths are entirely preventable. So let's begin with this overview. It's a pretty simple narrative if we look at the overall prevalence of and number of smokers. Both have been decreasing since 1965. The red line highlights the number of smokers. Where there were once more than 55 million smokers, we have a little more than 35 million now. Prevalence peaked at a little under 45% in the 1960s. That is now 14% of all adults. But aggregate numbers often misrepresent what's going on in subgroups. So let's hit the next slide. Let's start with this one, education level. And we find it pretty startling. If we look in 1965, these 4 main education groups were pretty even in terms of prevalence. Some were doing 40 and 45% of every education group smoked. But look what happens over time. All the groups went down, but the slopes of the declines are very different. The college grads are scarcely above 5% smoking rates now, which is stunning, and probably why many of you might think that smoking is much better than it really is. But look at those with a high school education or less. It's still well above 20%. This is 4 times the rate of college grads, and we have a long way to go to remedy this disparity. Let's go to the next slide. If we look at socioeconomic status, it's a similar story. So the narrative in these figures starts in 1990. In 1990, there were already was a divergence in these groups of this is the federal poverty line. So how much is your household income as a proportion of the federal poverty line, which varies, of course, by household size, the number of children, etc. But a far lower percentage of wealthier Americans smoke. And by 2016, these disparities were no better, and in fact, especially for women, were somewhat worse than they were in 1990. Next slide. Race and ethnicity is another interesting and important story, and there is a divergence for certain. Indigenous people in our country smoke at far higher rates for both men and women, but we see smoking going down in almost all groups and at fairly similar rates. The takeaway here is that we need to work harder within the groups that are higher in their smoking prevalence rates. Next slide. This slide tells a disturbing story about smoking among those experiencing serious mental illness. Compared to the group with no recent serious mental illness, we're looking at a prevalence more than double, close to 30% compared to 14% among those without serious mental illness. If we go to the next slide, we can see that there is a major variation among the types of major mental illness. As two examples, I draw your attention to nearly half of those with bipolar disorders currently smoke, and nearly 60% of those with schizophrenia smoke as well. Next slide. If we examine smoking in the military, in general terms, we see a very oh, you know what? We're on the wrong slide. Sorry, go to the advance one more slide. Sorry. That's overall smoking prevalence has dropped more steeply in the military compared to the civilian population. It is now coming closer to matching this prevalence. We credit effective policies for making this happen, but cigarettes are not part of soldiers' rations anymore. It is illegal to sell discount cigarettes on military bases. And in fact, the military has publicly said that smoking undermines its military readiness. These are all great things that have happened. So many young people in the past decades became addicted to smoking while serving in the military. But this trend shows a disturbing trend by pay grade. That those military members at the bottom of the pay grade are smoking at much higher rates than those at the top. Keeping in mind that those are not daily smokers, but also include some occasional smokers, we see that some 30% of those in the lowest pay grade report smoking. This mirrors very much what I showed a few minutes ago in terms of education and socioeconomic status. Actually, could you guys flip back to the previous slide and let me talk about that? So one other thing we have to note is that compared to that, the LGBT community also is suffering a much higher rate of tobacco use. It is another problem that we need to figure out some way to address. In lots of cases, the rate is double that of heterosexual peers. So advance two more slides. Let's get back on track. All right, so you might ask, rightly, why are all these disparities here? It's a really important question. To begin with, one of the main reasons for these disparities is that the tobacco industry has figured out which subpopulations are most vulnerable and purposefully and very effectively targets them. They tailor their advertising and promotions, including particularly the discounting of cigarettes and sponsorships to these groups. Second, and this is related to the first one, but also a little different, we see that the environment in places with more smokers is different. Next time you're in two different communities, one that is affluent versus one that is less so, I ask you to look around and see how easy it is to buy cigarettes. I practically guarantee you that you'll find it much easier to find a place to buy cigarettes in less affluent communities. Third, many of these groups are getting even far less exposure to anti-smoking messages. We are failing as a society to do this effectively, and we have to try harder. Next slide. Finally, what else should we be doing? I want you to do what I do. At every chance I get, I shout from the rooftops that this challenge is still enormous in the US. Moreover, it is disproportionately affecting many of our most vulnerable populations. It is being perpetrated by a malevolent industry that knows precisely what it is doing. It is morally twisted and wrong. I think e-cigarette use among affluent youth is a real problem, and I worry a lot about it, but I go to bed much more deeply worried about the challenges I have described today. We need to grow our partnerships with groups that are successfully making inroads in these communities. We need to figure out who these groups are and support them. We might not have direct resources to help them all, but we feel we have an enormous footprint in a loud and respected organizational voice as the American Cancer Society. And I think groups like this are doing a good job of getting into the weeds of addressing these issues. Finally, the next slide. I want to thank you all for listening and more importantly for caring, and I'm open for questions if that's what we have time for.
Definitely. Thanks, Alex.
No trouble.
Any questions for Alex about who's still smoking or what you're seeing in your communities?
I just have a comment. A few years ago, I discovered that in Pittsburgh, all the gay bars were being, not all of them, but most of them were being subsidized by Camel cigarettes to the tune of tens of thousands of dollars. And what they were doing was putting the Camel logo on napkins and coasters and all that kind of stuff, putting posters in the bars, actually selling packs of cigarettes behind the bar. So it was a really blatant attempt on their part to market to that community. And I just about got thrown out of to Alex's point here that he just made, I could just got thrown out of several bars because I commented and was, calling them to task about why they were doing this. Think it's still going on. It's not probably as open as it was before, but they're still marketing heavily to the gay and lesbian community.
It was like that here in Atlanta too. In fact, not even too long ago, they were still giving out matchbooks. I haven't seen matches in forever. Yeah.
When I lived in Chicago, I worked in skilled care nursing facilities, and most of the residents there were all essentially, low income because a lot of their SSI or whatever assistance they were getting from Social Security was cut down. When you go into long-term care or just care in nursing homes, and they would actually sell cigarettes at the front desk like 4 different times a day at pretty much every single nursing home that I visited clients at. And I thought that was astounding and really just, I was really surprised to see that.
Wow. Yeah, that is surprising, Celine.
I also have a comment about that. Is here in San Francisco, we actually have several laws that keep cigarettes out of places, but we don't have really any enforcement of it. I can literally go to the bodega right next door to us and buy a single cigarette if I wanted, which has been illegal for years and years and years, but you can still do it basically anywhere here in the Tenderloin.
Wow. Oh.
Long way to go.
Long way to go, for sure.
Mm-hmm.
Other questions? Anybody? I have a question for the group. I'm just interested, and we haven't talked much about this with this group, but I'm interested in anybody have experience with Native American communities, or anybody having, subpopulations within your communities where there's more Native Americans, and the tobacco use rates or challenges there? We don't have anybody specifically. I was just curious if anybody been working in that area or had ideas or thoughts on it.
Laura, this is Linda Bailey.
Yeah.
I just wanted to mention, listening to Alex and talking about vulnerable populations and populations with higher rates, by marketing quit lines to those populations, we've been able to really improve the reach of quit lines to populations with high tobacco usage rates. And one of them, of course, is American Indians. And some of it has been marketing, and some of it has actually been doing focus groups or with Native groups doing talking circles to learn more how to engage them and how to keep them engaged in treatment services. And National Jewish and Optum both have developed special protocols for helping American Indians and Alaska Natives quit commercial tobacco use. And so these protocols support the use of sacred tobacco or tobacco in cultural settings, but really helps quit the tobacco that people are using in terms of commercial cigarettes. So just wanted to mention that if you're working with your quit line and there's a large enough population in your state, you may be able to look at some of those breakouts by racial ethnic group and also by other groups that have very high prevalence. And if not, we have national data if that would be useful to any of the public housing agencies or community health centers in their work.
Great, that's great to hear, Linda. Thank you for both reminding me about that. I think I knew some of that, but I didn't know all the details, so that's great. Yeah, great to hear. Great, and then certainly, I know all of you, the subgroup of patients with behavioral health conditions is a big part of the populations that you all are serving, so that's another big focus area for us, Alex. So we will probably talk a little bit about that as we move into the next part of our session today. Any other questions on the didactic part or around the disparities of who's still smoking and who's still using tobacco?
I did have a quick question.
Yeah.
Do you have any data on how many veterans smoke when you mentioned the military?
Yeah, there is data available for that. We could break it out using the National Health Interview Survey. Usually it's just higher than average. It's partly a reflection of lower socioeconomic status. But would you like me to send you an email with that number?
That would be fantastic.
Yeah.
Okay.
Alice, if you want to send it to me, I'll disseminate to everybody.
Okay, I'll go find it.
Thank you.
Great, thank you.
No problem.
That's great. Another important population, especially as we think about veterans and their housing situations and the people that you all are serving. So that's a great question, Heath. Thank you.